Good morning, student. I am Dr. Prachi Shinde, and today we will study about the ophthalmology. In that, we will learn today that is diseases of the lacrimal apparatus. So, the diseases of the lacrimal apparatus consist of many diseases. First of all, we would learn about the anatomy of the lacrimal apparatus. So, when we study about the lacrimal apparatus, in this diagram, we can see that this is a lacrimal gland, and from that lacrimal duct is coming. This is a eyeball, and this one is a upper canaliculus, and this is a lower canaliculus, which connect to each other or meet to each other and form a common canaliculus, and which open into the lacrimal sac. So this one is a lacrimal sac, which is continue as a nasolacrimal duct and open in the wall of Hasna. So this is all about the structure of the lacrimal apparatus. Second one is a structure of the tear film. So when we study about the tear film, there are 4 to 5 structure in the tear film. First of all, there is a lipid layer, which is a zero point 0.1 mm micron. Then aqueous layer, which is 6.5 to 7.5 micrometer. Then mucin layer, which is 0.02 to zero point 0.05 micrometer. Then the membrane of glycoprotein with the microvilli. So this is the structure of the tear film, consists of lipid layer, aqueous layer, mucin layer and membrane of glycoprotein with the microvilli. So next one is diseases of the lacrimal apparatus. In that, first of all, we will learn about the dry eye, that is the dry eye syndrome. So when we study about the anatomy, that is the structure of the lacrimal apparatus and structure of the TM film, then we will learn about how the lacrimal gland form and which was continues in the eye as a lacrimal duct. Then this one is the upper canaliculus, lower canaliculus, commonly meet as a common canaliculus, which is open in the lacrimal sac and continue as a nasolacrimal duct and open in the wall of the husky. So, the diseases of the lacrimal apparatus are divided into the two groups, that is the abnormalities of the lacrimal gland and defect in the drainage system. So, when we study about the abnormalities of the lacrimal gland, firstly there is the excessive tear secretion. So, when there is an excessive tear secretion due to the reflex stimulation of the main lacrimal gland, which result in the excessive tear secretion. And when there is a deficient tear formation, that is the atrophy of lacrimal duct and conjunctival scarring leading to the occlusion of the main and accessory lacrimal gland. So, this is the abnormalities of the lacrimal gland. And third one is a characteristic swelling with the S-shaped upper lid. That is the neoplasm or inflammatory diseases of the lacrimal gland. So, when there is the abnormalities of the lacrimal gland like excessive tear secretion, second is a deficient tear formation, and third one is a characteristic swelling with the S-shaped upper lid, which lead to the abnormalities of the lacrimal gland. And second is a defect in the lacrimal drainage system. That is, when there is a defect in the drainage of lacrimal system, then there is appearance of the diseases of lacrimal apparatus. So it is due to the cause watering from the eye and obstructed lacrimal sac may be chronically or acutely inflamed. So when there is a drainage of lacrimal drainage system, it is which cause watering from the eyes. So there is watering from the eyes, and when there is obstructed lacrimal sac, may be chronically or acutely inflamed. Acute inflammation causes a cellulitis of the sac and surrounding structures and lacrimal abscess formation. And chronic inflammation causes the painless swelling in the sac region with the regurgitation of the pus through the puncta when pressure is applied to the sac area. Then, when there is an excessive tear formation or poor drainage, since the region is blurred by the tears and discomfort causes by the overflow of the tear onto the cheek. So, when there is a excessive tear formation or the poor drainage, this result in a discomfort caused by the overflow of the tears onto the cheek. And when there is a deficient tear formation, may cause the loss of the eye and is associated with the ocular surface disease, that is OSD, that is keratinization of the cornea and conjunctiva. So this is all about the signs and symptoms of the diseases of lacrimal apparatus. Then we was learn about the diseases of the lacrimal gland. Before that, we will learn about the dry eye syndrome. So, the dry eye per se is not a disease entity, but a symptom complex occurring as a sequelae or to deficiency or abnormality of the tear film. So, what is the dry eye? Dry eye is a not disease entity, but it is a symptom. It is a complex occurring as a sequelae of deficiency and abnormalities of the tear film. So, a dry eye syndrome is said to exist when the quantity or the quality of precorneal tear film is insufficient to ensure the well-being of ocular epithelial surface. So, etiology when we see that there is first is due to the aqueous tear deficiency, second one is a mucin deficiency dry eye, third one is a liquid deficiency and abnormalities, impaired eyelid function and epitheliopathies. So these are the causes of the dry eye syndrome. Then the clinical feature. So the dry eye is a multifactorial disease of the tear and ocular surface that result in a discomfort, visual disturbances and tear film instability with the potential damage to the ocular surface, and it is accompanied by increased tear osmolality and inflammation of ocular surface is seen in dry eye. So, in the most of the situation, it results from a localized immune-mediated inflammatory response affecting both of the lacrimal gland and the ocular surface. So, when we see the clinical features in that, the symptoms of dry eye suggestive of dry eye include irritation, there is a foreign body or sand-like sensation, feeling of a dryness, itching, non-specific ocular discomfort, and chronically sore eye not responding to a variety of drops instead earlier. And in the signs, in that we can see that signs of a dry eye include a presence of a springy mucus and particulate matter in the tear film with the lusterless ocular surface and conjunctival xerosis. with the reduced or absent marginal tear strip and corneal changes in the form of the punctate epithelial erosion and filament. So these are the signs and symptoms of the dry eye. The other commonly used term for the dry eye are the tear film dysfunction. It is a disturbance in the tear film function owing to change in a lipid, water or the mucin component of the tears. Second is the ocular surface disorder. And third one is the keratoconjunctivitis sicca. It is a deficiency of aqueous component of the tear film. In that there is a primary and secondary cases. That is primary in that there is the involvement of lacrimal gland alone, and in the secondary when there are additional feature of connective tissue disorder. So when we will learn about the symptoms of dry eye are typically worse during the night time or awaking from the sleep, as the sleep decreases the tear production, and they include a foreign body sensation, that is a sandy or gritty sensation, transient blurring of vision, excessive stringy mucus, burning sensation, photophobia, intolerance to draft and wind, and constant awareness about the eye itself. And when we see about the signs of the dry eye, then it includes a precorneal tear film, that is increased amount of mucus strand and debris in the upper and lower tear menisci, that is meniscus floaters. And marginal tear film, that is tear meniscus, is the marginal tear strip is reduced and it contains mucus and debris. So normally the lower tear meniscus height is about the 1 mm. In the conjunctiva, we can see that there is a hyperemia of the conjunctiva and appearance of the fold on the temporal slide, especially on the abduction. Papillary conjunctivitis, a non-specific reaction, is seen. Then in the cornea, there is a superficial punctate keratitis. In that, there is the involving of inferior cornea, which is stained by fluorescence and rose bengal, and filaments, that is are short tail that hang from a corneal surface. They are composed of central mucospore and encased by epithelial cell and stained with the rose bengal and fluorescence. So mucus plaques are attached loosely to the corneal surface and are also stained by rose bengal dye. So there is a thinning occur in a severe dry eye and sometimes with the perforation. So in the treatment of the dry eye, we can see that at the present there is a no cure for the dry eye. The following treatment modalities have been tried with the variable result. First one is the supplementation of the tear substitute. That is, these are available as a drops, ointment, and slow release insert. Mostly available artificial tear drops contain either cellulose derivatives, example 0.25 to 0.7% methyl cellulose and 0.3% hypromellose, or polyvinyl alcohol, that is 1.5%. Second is a topical, that is cyclosporine is reported to be the very effective drug in case of the dry eye. Third is a mucolytics. Fourth is a topical retinoids. Fifth is a preservation of existing tear by reducing evaporation and decreasing the drainage. So this is all about the treatment of the dry eye. So in that cases, preservation of existing tear, that is reduction in room temperature humidifiers, that is example are swimmers goggle, moist chamber goggles we can use, plenty of intake of the drinking water with the lid tapping, and tarsography to prevent exposure keratitis with the punctate occlusion, that is, it is to preserve the natural or artificial tear in contact with the ocular surface for a longer time. So, and supplementation of tear in that case, cellulose, that is methicellulose, polyvinyl alcohol, povidone, sodium hyaluronate, they are used either alone or in the combination. So there is a drops, ointment, gel tear. The gel is clear synthetic polymer of acrylic acid which dissolve very slowly. So these are the treatment we can use in the case of the dry eye. Next one is the watering of the eye. So watering from the eye, it is characterized by the overflow of the tear from the conjunctival side. The condition may occur either due to excessive secretion of the tears, that is hyperlacrimation, or may result from obstruction to the outflow of normally secreted tears, that is the epiphora. So, when watering is associated with the blurring of vision and continuous discomfort caused by the tear running down the cheek. In the all instances, it is necessary to find out whether there is excessive production of tear, that is lacrimation, or its defective drainage, that is the epiphora. Lacrimation, there is excessive secretion of the tears due to the reflex stimulation of the lacrimal gland. So, in the etiology, we can see that there are causes of hyperlacrimation. In that, first is the primary hyperlacrimation, and second is a reflex hyperlacrimation. So, when there is a affection of the lid, conjunctiva, cornea, uveal tissue with the acute glaucoma and endophthalmitis and panophthalmitis with the orbital cellulitis, this can result in a hyperlacrimation. Third one is a central lacrimation, that is psychical lacrimation. It is due to the emotions. When there is a emotions are increased in the patient, so there is a central lacrimation seen in that cases. Psychic stimulation as in weeping or in laughing. Second is the irritation of the cornea or conjunctiva by the dust, fume, chemical, foreign body, inflammation, etc. And in yawning, coughing, sneezing or vomiting with the exposure to the bright light. And epiphora, that is defective drainage of the tear due to the fault in the lacrimal passage. And causes are when there is a mechanical obstruction in the drainage system due to the congenital absence or occlusion of the puncta. And canaliculitis, that is canalicular obstruction, conjun- congenital dacryocystitis, chronic or acute dacryocystitis with the neoplasm of the lacrimal sac, nasal pathology like polyps, tumor in the inferior meatus of the nose. Lacrimal pumps failure due to the lower lid laxity, weakness of orbicularis oculi as in Bell's palsy, and ectropion due to the other causes. So, the causes of epiphora in that when there is inadequate drainage of the tear may occur due to the physiological or anatomical mechanical causes. In that, first is the physiological cause and second is the mechanical obstruction. In that mechanical obstruction, first is the punctal causes are include like eversion of lower punctum and punctal. Second one is the punctal obstruction. Next is the causes in the canalicular. then causes in the lacrimal sac, and then causes in the lacrimal duct. So when there is a causes in canalicula, lacrimal sac, nasolacrimal duct in the punctum, this lead to the mechanical obstruction, which lead to the hyperlacrimation. So these all about the watering of the eye, that is hyperlacrimation. Next topic is dacryocystitis. So what is the dacryocystitis? Dacryocystitis is an important topic in the ophthalmology. So dacryocystitis, it is an acute or chronic inflammation of the lacrimal sac, and it is the sequelae of obstruction of the nasolacrimal duct or the sac itself, followed by a bacterial infection. So, when there is a inflammation of the lacrimal sac, may be acute or chronic, then it's called as a dacryocystitis, and it is sequelae of obstruction of nasolacrimal duct or the sac itself, and followed by the bacterial infection. So it may be a congenital in that primary and secondary type. In the primary, there is acute and chronic, and in secondary, it is seen in the infant and in adult due to the some disease. So when we can see a etiology of it, that it is commonly seen among the newborn infant, that is the congenital type, and middle-aged women, that is 7 times more common than the male. It is seen left side more commonly affected than the right. That ratio of left to right is 9 is to 1. It is mostly seen in the left side and in the middle-aged women. More common in the lower socio-economic status. Causes are lacrimal passage, that is proper in the nasolacrimal duct, blocked due to the narrowness or the chronic inflammation of the sac. In that there is a nasal factor like a DNS, hypertrophied inferior turbinate, nasal polyps, etc. With the following primary conjunctivitis and infection spreading from the nasopharynx. Organisms responsible are pneumococcus, most common, then streptococcus, staphylococcus, mycobacterium, chlamydia, etc. So in that, firstly, the type is the acute dacryocystitis and the chronic dacryocystitis. And in the chronic dacryocystitis, there is a congenital type and adult type. So congenital, it is due to the failure of canalization of nasolacrimal duct, and lumen is blocked by the epithelial debris, and it may be bilateral. So this is the diagram of acute dacryocystitis, that is the stage of lacrimal abscess. So when we study about the acute dacryocystitis, it is a suppurative inflammation of the lacrimal sac with an associated cellulitis of the overlying tissue. So, when there is acute inflammation of lacrimal sac associated with the cellulitis of overlying tissue, it is called as the acute dacryocystitis. The onset is acute and there is a painful swelling below the inner canthus of the combined with the widespread cellulitis. The swelling is tender with the enlargement of the submandibular lymph node. Constitutional symptoms like fever, malaise, etc. are present. An abscess may form with the perforation of the skin just below the medial palpebral ligament, leading to the formation of lacrimal fissure. That this is the diagram of lacrimocystitis, and this is the formation of a stage of external lacrimal fissure in the acute episode. So where abscess may often form with the perforation of the skin just below the medial palpebral ligament leading to a formation of a lacrimal tissue. So when we see the sign that is the epiphora with the purulent discharge at inner canthus and on patient on the sac with the regurgitation of the purulent matter, initially it is sterile but soon it gets infected. And in a treatment, we can see that the pressure over the sac may push the content down. Thus, the patency of nasolacrimal duct is achieved with the probing of nasolacrimal duct. And delay in the treatment may cause a complete secretorial obstruction of the duct. So, this is diagram of the acute dacryocystitis. In that, we can see the stage of the lacrimal abscess. This is the dacryocystitis, and this is a stage of the external lacrimal fistula in the acute dacryocystitis. So, the treatment of acute dacryocystitis consists of the local or hot compresses 3 to 4 times daily, broad spectrum systemic antibiotics, and topical antibiotics 4 to 6 times daily, with the systemic analgesic with antacids. In case of the lacrimal abscess, it is best drained by a skin incision. And in case of the lacrimal fistula, whether formed naturally or artificially by drainage, it is usually closes when the patency has been restored by the DCR operation. Otherwise, the tract is excised along with the dacryocystectomy, that is DCT operation, and when everything is resolved, a DCR or DCT operation has to be done as an elective procedure. So, next topic is a chronic dacryocystitis. In the chronic dacryocystitis, this is seen most frequently in the newborn, infant, and in the middle-aged woman. The chief symptoms are watering and a chronic mucopurulent discharge at the inner angle of the eye. And there is the regurgitation of the pus of a mucus through the puncta on pressure over the sac area. So, in the etiology, we can see adult over the middle age, 75% in a male, may be uni or bilateral, and predisposing factor shows that stricture of the nasolacrimal duct due to the narrowness of the body canal and hypertrophy inferior nasal turbinate with the nasal polyp DNase each influence. Then, exciting factors like infection of stagnated contents of the sac, that is pneumococcal, streptococcal, and staphylococcus. Dacryocystitis pathology, in that we can see that there is a stagnation of the content of the sac due to the stricture due to the stricture of the nasolacrimal duct. In that there is an infection of the content and sac wall become inflamed. Epithelium of the sac wall multiplies to form a several layers and vascularity of the wall increases. In that sac wall become atonic and sac content becomes mucoid and then mucopurulent. So firstly there is the stagnation of content of sac due to the stricture of nasolacrimal duct. It leads to the infection of content and sac wall become inflamed. So the epithelial of sac wall multiplies to form a several layer With the vascularity of the wall is increased and sac wall become atonic with the sac content become mucoid and then mucoid. So symptoms is the epiphora. And in the sign we can see in the catarrh stage that there is a watering from the eye with the mild conjunctiva, hyperemia at the inner canthus, with very little or no regurgitation of the content of sac on pressure on the sac. On syringing the sac, fluid regurgitates through the upper punctum and with the no local swelling over the sac area. So, next is in mucocil stage. So, this is a diagram of the mucocil stage of dacryocystitis. In that, we can see that in addition to the watering swelling over the sac area, on the pressure over the sac, there is a mucoid material regurgitate through the punctum and sometimes both the canaliculi are blocked. There is a no regurgitation on pressure, insisted mucocele and conjunctival hyperemia at the inner canthus. So, in the mucosal stage, there is addition to the watering and swelling over the sac area and pressure over the sac. So, mucoid material is regurgitated through the punctum and sometimes both the canaliculi are blocked. There is a no regurgitation on pressure with the insisted mucosal. So, it forms a insisted mucosal and conjunctival hyperemia at the inner canthus. Third is a pycosis. When there is a conjunctival hyperemia is more pronounced and swelling over the sac area is not tender. And when there is a no redness of the skin over the swelling with on pressure of over the sac there is a mucopurulent matter through the punctum with the watering continues. So, in the pycocele stage, there is a conjunctival hyperemia, which is more pronounced, and swelling over the sac area is not tender, with no redness of the skin over the swelling. On pressure over the sac, there is a mucopurulent matter through the punctum, with the watering is continued. And in the complication, we can see acute dacryocystitis. Then corneal ulcer, that is the hypopyon ulcer due to the pneumococcus and chronic conjunctivitis. So next topic is acute dacryocystitis. It is acute suppurative inflammation of the lacrimal sac. It is usually a acute exacerbation of the chronic dacryocystitis and causative agent like streptococcus, pneumococcus, staphylococcus. Due to that organism, acute dacryocystitis is occur with the acute suppurative inflammation of lacrimal sac. So it is an acute exacerbation of the chronic dacryocystitis. Sac is filled with the from frank pus with abundant PMNL and anterior sac wall gives way and inflammation spread to the surrounding tissues, that is pericystitis. And finally, the lacrimal abscess, which usually bursts on the skin, and after draining of the pus, the inflammation subsides and sac becomes shrunken and fibrous. So, when the sac is filled with the pus, and there is an anterior sac wall gives way and inflammation spread to the surrounding tissue, so it leads to the pericystitis. And finally, lacrimal abscess, which usually burst on the skin And after drainage of the pus, the inflammation is subside and sac becomes shrunken and fibrous. So symptoms of acute dacryocystitis is severe pain and heat over the sac area, pain radiating to the frontal region, there is a fever, epiphora, and in the signs we can see that there is a swelling and redness of the skin over the sac area with the edema of the skin of the lid and the side of the nose. So it is tender and hot skin over the sac with the congestion of conjunctiva and enlarged submaxillary lymph. So, when we can study about the symptoms, that is what is seen in the patient in acute dacryocystitis, in that we can see a severe pain and heat over the sac area, pain radiating to frontal region with the fever and epiphora, and in that we can see that there is swelling and redness of the skin over the sac area with the edema of the skin of lid and the side of the nose. So it is tender and hot skin over the sac, congestion of conjunctiva and enlarged submaxillary lymph node. And the complication of acute dacryocystitis is that there is a osteomyelitis of lacrimal bone, that is internal lacrimal fistula opening into the nose. So when the lacrimal fistula is open internally into the nose, it leads to the osteomyelitis of the lacrimal bone. Second one is the orbital cellulitis and facial cellulitis may occur as a complication of the acute dacryocystitis. Then secondary dacryocystitis. So the secondary dacryocystitis is seen in infant. It is rare. It is a very rare condition that's seen in an infant and originate from the tubercular or syphilitic affection of the surrounding bone. In the adult, it is seen as a trachoma with the tubercular or syphilitic affection of the surrounding bone and leprosy. So when it is seen in an infant, rarely it originates from tubercular or syphilitic affection of the surrounding bone, and in adult it is as seen as a trachoma with the tubercular or syphilitic affection of the surrounding bone and leprosy. So, the treatment of the acute dacryocystitis consists of when there is a before the abscess formation and localization of inflammation, the heart compresses over the sac area, then antibiotics, analgesics can be used, and when the inflammation has localized, the vertical incision to drain the pus with the removal of the sac when inflammation is completely subsided. So when there is the inflammation has localized, so vertical incision is required to drain the pus, and